Bueno, bienvenidos a todos nuevamente al Cornea Day de Oftalmo Córdoba 2020. En este momento vamos a iniciar la segunda masterclass que va a estar dada por el profesor Harminder Dua desde Inglaterra. El profesor Dua es profesor en la Universidad de Nottingham de ese país. Fue el doctor que hizo un cambio en la anatomía quirúrgica de la córnea, redefinió la anatomía de la córnea y hoy nos va a estar hablando de desprendimiento de membrana de Descemet, un tema muy interesante que tiene para darnos. Así que bienvenido, profesor Dua, un gran gusto que esté con nosotros nuevamente aquí en Oftalmo Córdoba. Puede iniciar su presentación.
Hello. Good afternoon to all of you, and greetings from Nottingham. It's my pleasure to be part of this session, and I apologize that I'm going to speak in English. I hope that will be acceptable to you. I'm going to take you through some concepts in Descemet's membrane detachment, which we have missed so far for more than hundreds of years. So I'm just trying to get my slide to move forward. Yeah. If you look back at the history, the first recorded case of Descemet's membrane detachment was approximately more than 100 years ago by Ernest Fuchs. And usually it was seen and still is seen after multiple intraocular operations, which are complicated, like if there's a nucleus drop in cataract surgery and so forth. And this Descemet's membrane detachment, which is post-operative or spontaneous, is very different from the Descemet's membrane detachment we see after DMEK or Descemet's membrane endothelial keratoplasty, for example. So I'm not going to talk about the endothelial keratoplasty-related Descemet's membrane detachment, but only the other types that all of us who do any surgery will see from time to time. So the symptoms of this condition are persistent edema of the cornea in the area of the detachment. Usually this edema does not spread beyond the area of detachment for quite a while, which is interesting. The vision is affected if the pupil is involved. And on slit lamp and OCT, we can see a very hyperreflective or a sharp line at varying distances from the cornea in the anterior chamber. OCT will always show Descemet's membrane as a double contour line. When we see two lines running along as we look at the Descemet's membrane, they're parallel to each other and are very bright with a dark space in between them. This is exactly how it looks. Both of them are the Descemet's membrane. One is the anterior surface of the Descemet's membrane, where the refractive index between the aqueous and the Descemet's is high. Then there's the thickness of the Descemet's membrane where it is dark. And then again, the refractive index of the endothelium and the aqueous, the difference is high, so you see another bright line. So in other words, even if you take the endothelium away, and we have done that in experimental eyes, you will still see two lines. So that is the OCT feature of the Descemet's membrane. And this is in vivo. This is by ultra high resolution, which Bezeva et al. Have shown from Canada, that this is what we are used to seeing. We see this double line, but if you magnify that red box over here, you can see this, the last row of keratocytes and the double contour Descemet's membrane line, and in between is the pre-Descemet's layer or the Dual's layer over here. And what you see on histology is the same, the Descemet's membrane with the endothelium, the last row of keratocytes, and that layer over there is the pre-Descemet's layer or the Dual's layer. Now, if you look at what we know already about Descemet's membrane detachment and its classification, they say it's active when it is pushed back into the anterior chamber, or it can be passive if there's scarring in the anterior chamber and something is pulling the Descemet's membrane away from the cornea. McCool in 1977 came with this classification where he said it can be planar, which means that the Descemet is separated from the endothelium by only 1 millimeter or less. If it is more than that, then he called it non-planar. And recently we had a classification based on OCT, by Agarwal's group, where they said it can be rhegmatogenous, tractional, bullous, and complex. Now, what we see is that whatever the cause, the symptoms are always the same, and the causes can be spontaneous. It can be due to trauma, which can be surgical or non-surgical trauma, and it can be due to tumors and due to inflammation. And it can be early or delayed in the presentation. So all those make a difference in terms of the manifestation and in terms of the options for treatment and the outcomes of the treatment. Now, here is one paper that was published in 2017 where it said Descemet's membrane splitting following deep anterior lamellar keratoprosthesis. And it shows over there with the two arrows that the Descemet's membrane has split into two. And we have seen this even with the DALK operation, when the deep anterior lamellar keratoplasty. In the past, there were fairly numerous reports saying the Descemet's membrane splits into two. Now, to understand what I'm going to tell you, let's go back to basics, just 3 slides. So if you take a human cornea and inject air, what you'll find is that you can see air escaping at the periphery, but what's more important is that in the center, this bubble forms, starts in the center and moves outside. And this bubble is what we call the type 1 bubble, and it is made up of the pre-Descemet's layer and the Descemet's membrane. It's a separation of pre-Descemet's layer, Descemet's membrane, and the endothelium. That's a type 1 bubble. And sometimes this happens. So if you look at what's going to happen in this video, it should work, but yeah, so what you'll see is when we inject the air, the very thin-walled bubble forms. You can see over there, and it goes across the whole cornea. And this, again, in this little video, you'll see 2 thin-walled bubbles are starting, and that is the equivalent of a type 2 Descemet's membrane. This is the type 2 bubble, which is air between the Descemet's membrane and the pre-Descemet's layer. So we had the type 1, which was air between the stroma and the pre-Descemet's layer, and the type 2, which is air between the pre-Descemet's layer and the Descemet's membrane. And sometimes you get what we call the mixed bubble, where you have the type 1 in the center, and what you can see over here, there's air between the pre-Descemet's layer and the Descemet's membrane, so it's called mixed, type 1 and type 2 together. Again here, the center one is the type 1, and then this big horseshoe of a type 2 bubble. Now, what people used to think, like I said before, is that this is a split in the Descemet's membrane. But when you take a Descemet's membrane from either a type 2 bubble, like I showed you in the previous video, or from a mixed bubble, and you look at it by histology, you will find there is never a split. Normally, they say the split occurs between the banded layer and the non-banded layer, but you can see there is never a split. So the Descemet's membrane does not split as we believe. It is the Descemet's membrane separating from the pre-Descemet's layer. So how does this relate to the topic of my talk today? And this can be even my summary slide. In fact, it will be my summary slide as well. Just like the bubbles, if you look at the Descemet's membrane detachment, you get 3 types, exactly like the bubbles. The type 1, we call this, where there's the pre-Descemet's layer and the Descemet's membrane, not the Descemet's membrane alone, but the pre-Descemet's layer and the Descemet's membrane are detached. You can get a type 2 detachment, where it's only the Descemet's membrane that has detached, or you can get the mixed type, where you can see the pre-Descemet's layer, the Dewey's layer, is also detached, and the Descemet's membrane has detached, and the two are separated from each other. And that is something new. This concept and this are completely new to our thinking of Descemet's membrane detachment. So we have 3 types, not just this one type, which we all believe is happening. So we'll take a look at the picture over here. Chronic post-operative corneal edema. On the slit lamp, you can see a line, and then here you can see this is the classic appearance of a type 1 detachment. Pre-Descemet's layer, Descemet's membrane, endothelium. This will always appear like a very straight line, like the chord of a circle. It's very taut, a very tight line, like you see here and here. And this, when you do histology, we have done histology in 5 eyes of this type 1 detachment. And you can see in the slit lamp, it appears like this. This is following an eccentric graph. But what you see here is that the dark line there is the endothelium, the Descemet's membrane banded, non-banded layer, and the pre-Descemet's layer is anterior to it. Pre-Descemet's layer has come away, and some cells have now started migrating on the anterior surface of the pre-Descemet's layer. So histology confirms the concept that when you get a tight detachment like that, it is a type 1 with all the 3 layers, the pre-Descemet's layer, Descemet's membrane, and endothelium. And here are some other examples, and because the distance from the cornea is less, we can call them all as planar detachments, means less than 1 millimeter. Now, sometimes when we do the Dalk operation, we see these strands of stroma between the deep stroma and the anterior surface of the pre-Descemet's layer. So these are strands that are extending from the deep stroma. Sometimes they can be very thick as you go more towards the periphery. Towards the center, they're very light and thin. These strands extend from the posterior surface of the deep stroma onto the anterior surface of the anterior surface of the pre-Descemet's layer or the Dewey's layer. So when you see on OCT, this picture, a tight Descemet's membrane detachment, and occasionally you will see this connection. That clearly tells you that it is the pre-Descemet's layer that has separated, not the Descemet's membrane, because you never get such a strand extending between the pre-Descemet's layer and Descemet's membrane. It is always between posterior stroma and the pre-Descemet's layer. So here's another example. This patient had chronic edema following graft failure. You can see the detachment over there. And here there's another strand connecting the two. We had histology on this eye. And you can see on the histology, what is interesting is that the keratocytes have migrated into the stroma of the pre-Descemet's layer. Normally it is acellular or very, very few cells, but here they're quite a bit. So what happens with time is these keratocytes migrated into the stroma. They become fibroblasts, myofibroblasts, they contract, and they make the Descemet's membrane more tight and more scarred. So the more the scarring has happened, the more difficult it is to put it back just with a bubble of air when it comes to the treatment. Now, these are examples on OCT of a type 2 detachment where you can see that it's quite wavy. It's not like a straight line, it's wavy. See, it's very wavy like that. So when you see that, it is only Descemet's membrane and it is your type 2 detachment. But sometimes you get a mixture, as you see over here. And again, we have histology to show that there's a Descemet's membrane, then the pre-Descemet's layer is over there. At places it's attached, at places it's separated. And on OCT, you can see beautifully the pre-Descemet's layer and the Descemet's membrane appearing as this double contour line. So this is a mixed type. So you've got pre-Descemet's layer separated and the Descemet's from the pre-Descemet's layer. So they're both separated from the cornea and also from each other. And here again, you can see one example of where you can see there is the pre-Descemet's layer. So there's a type 1 detachment, but at places the Descemet's membrane has come away. And again, another example of OCT where you see these two lines. See, that is straight, and this is always more wavy. So it tells you the Descemet's membrane behaves very differently, like a wave compared to the pre-Descemet's layer. And here's another example which is quite interesting. This patient had cataract surgery, chronic edema, not settling. OCT was done. They found Descemet's membrane detachment. They tried to put air to get it back. It didn't work. They put SF6. It didn't work. Then the patient was referred to me. And I just reviewed the OCT and I could see that here there's one line. Here there are two lines beginning to appear. And then if you look further down, what you see is that the pre-Descemet's layer is there, but the Descemet's membrane has detached and is torn and is curled. So what you've got over here is a mixed type, which is torn. So again, the classification further progresses when you say the Descemet's membrane detachment can be type 1, type 2, or type 3, but it can be regmatogenous or non-regmatogenous, which means one or both layers can be torn. And that is what you see over here, where one layer has been torn. So clearly this cornea is not going to settle for quite a while until the endothelium grows back or we do an endothelial keratoplasty procedure. And here are other examples where you can see of rhegmatogenous. Here the type 2, the desmus has torn and it curls with the endothelium outside. Here again, like I showed you before, and here in acute hydrops, you see both of them are torn. So here's a predesmate layer, here's the desmus membrane, and there's a tear in both of them, and then you get this acute hydration of the inside of the cornea or the corneal stroma. Here's another example of a rhegmatogenous type 2 detachments where only the desmus membrane is torn and it has curled. So this is what I said, like in acute hydrops, it's always the case. Acute hydrops is not due to tear in desmus membrane. When you get tear in desmus membrane alone, you never get acute hydrops in keratoconus. You get acute hydrops when you get tear in desmus membrane and the predesmate layer, as you see over here. So this one part, as you move your section from the periphery to the center, you will see there's a type 1 detachment over there. And then as you move closer, this is the area of the tear. And you will see in the area of the tear, both the layers have torn, and then you can get the acute hydrops. Here you can see that's torn. It will also curl a bit, but not so much, as you can see over here. And that is the end, broken end of the other side. So you get tear in both these layers. And this is one of the last case I want to show you, very interesting, sent from a colleague in India. So this patient had a very extensive peripheral ulcerative keratitis, as you can see over here, excessive ulceration and spontaneous detachment. And this was a type 1 detachment, as we see on the OCT. And this patient was then treated with immunosuppression. It settled, there were some scars, but the cornea cleared and the detachment was still there. And you can see the cornea is now normal thickness. The type 1 detachment is still there. On OCT, it was confirmed. And even you can do specular microscopy and you can see there are some cells on the stroma. But because it was clear again, the cornea, they were able to do cataract surgery and implant, leaving this just as it is. They did not have to do an endothelial keratoplasty because the corneal edema had all gone. And what that means is that there might have been a microscopic tear somewhere from which the endothelial cells were able to migrate onto the back of the cornea, as they do when acute hydrop settles on its own. So we're learning a lot more now that we know about this layer and we know the predesmate layer exists and the implications in understanding corneal pathology. And also we know a lot about it as with regard to corneal surgery are all coming in front of us. And based on this, we can now design our treatments. So in summary, we have had a paradigm shift in our understanding of desmus membrane detachment because of the involvement of the predesmate layer. There's a complementary classification. So in addition to what we've already seen, as we've seen the planar and the non-planar detachments and the active and the passive detachments, we can add whether it's a type 1, type 2, or mixed, as seen in these three pictures, type 1, type 2, and mixed. Now, what I would request is that if you see, and I'm sure from time to time, all of us who practice surgery will see a desmus membrane detachment. From OCT, if you classify it according to this and try and treat it the way you think best, and let us look at the outcomes of the treatment. What my experience so far is that when you get it like this, if it is early, then the air bubble or SF6 gas or C3F8 will put it back and it will be attached. If it is late, so if the cataract or the operation or the spontaneous occurrence was some weeks ago, it will not, because it becomes very tight and it will not go up back like a curve. So we may have to do a desmetotomy just to cut in an arc around the back of the cornea with a sharp needle and then put it back. Whereas the type 2 detachment will settle, and the mixed detachment with air, this desmets may go back there, but that may not go back. So again, we will learn from each other's experience how we treat these three different types and find out the best way to deal with it. Thank you very much.
Nanchi. Profesor Dúa, realmente impresionante la clasificación que acabamos de ver sobre los desprendimientos de Descemet. Esa clasificación creo que va a ayudar a todos los cirujanos de córnea del mundo a entender muchas cosas que muchas veces no entendemos. Realmente admirable su trabajo, su dedicación, y muchísimas gracias por estar aquí en Oftalmo Córdoba 2020 con nosotros. Es un gran placer tenerlo aquí y lo invitaremos para próximas sesiones sin lugar a duda. Le mandamos un saludo muy grande desde Argentina y muchas gracias por semejante masterclass que nos ha brindado, que realmente ha sido muy, muy satisfactoria y muy, muy buena. Muchas gracias.
Thank you.
Queremos